Greetings to everyone. We hope that you have been finding this course Manage TB, an online course for doctors, useful. Today we are entering the 4th week and we are starting on the treatment of tuberculosis, having covered epidemiology and diagnosis. I am Dr. M.S. Jawahar. I am a physician and an epidemiologist, and I worked at the TB Research Center, the ICMR, for more than 30 years. TB is a disease of great public health importance. Among the historically famous killer diseases like cholera and smallpox and plague, TB today continues to be a major public health problem compared to all the other diseases which you have controlled to some extent or the other. TB started declining in the US even before TB treatment became available. As the slide will show you, even in the early 1860s, TB started declining before even treatment or even a vaccine became available. So, during this time, patients were treated in sanatoria where they were housed in airy, comfortable circumstances, they were given a good diet and they were given rest. And surprisingly, many patients got cured because of this. This is data from England and India on the outcome of sputum positive pulmonary TB patients who did not receive treatment. In India, the data is from Bangalore in the 1961 to 68, where treatment had not still become available. This was done by the National Tuberculosis Institute, and you will see that of 154 patients who were followed up for 1.5 years, 32% got cured, 25% died, and 43% still remained culture positive, transmitting infection in the community. At 5 years, 33% got cured, 49% had died, and 18% still were culture positive and transmitting infection in the community. Similar findings were seen in England, which shows that there is self cure in tuberculosis, but unfortunately we cannot predict who are the patients who will get cured, and therefore we have to treat them. The era of bacterial treatment for tuberculosis began in 1944 with the discovery of streptomycin by Selman Waksman, for which he was awarded the Nobel Prize for Physiology in 1952. After the discovery of streptomycin, many other drugs were discovered in very rapid succession. In 1948, para-amino salicylic acid was discovered, followed by isoniazid, probably the most commonly used anti-TB drug today, in 1952, pyrazinamide in 1954, cycloserine in 1955, and a host of other drugs. So, in a space of 20 years, there was rapid advancement in the discovery of anti-TB drugs. Unfortunately, after the discovery of rifampicin in 1963, there was no interest in developing TB drugs, because by this time there was a perception that TB had been controlled and there was no point in investing in drug development for TB. So, for a long gap there was no new TB drug being developed, and this situation changed in the 1980s, where TB started re-emerging in the western countries with the advent of the HIV epidemic and the emergence of drug resistance. So, after that now we have a series of new drugs being developed. We have a global TB drug pipeline, and as you may be aware, 2 new TB drugs have been licensed very recently. So, along with the development of new TB drugs, it became realized that you needed to treat TB with more than one drug. With the discovery of streptomycin, the first randomized clinical trial was done using this in patients with TB. It was very soon discovered that patients developed resistance and they got worse and they died. So, in 1952, the first regimen for TB treatment was developed using streptomycin, isoniazid and para-amino salicylic acid, and the duration was 24 months. In the 1960s, PAS replaced ethambutol with ethambutol and the duration was 18 months. PAs were a very unpleasant drug to take because of the bulk and the side effects. In the 1970s, with the advent of rifampicin, was added to streptomycin, isoniazid and ethambutol, and the duration was reduced to 9 to 12 months. In the 1980s, with the use of pyrazinamide, the duration was cut down to 6 to 8 months, which now we call short course chemotherapy. Pyrazinamide was discovered as early as 1954, but its use in tuberculosis became widespread only in the late 1970s, and this made the possibility of shortening TB treatment duration to 6 months. There have been many efforts to shorten this further to less than 6 months. They have not been successful, and research is going on now to find a shorter regimen for TB treatment. The currently recommended treatment regimens are the results of numerous clinical trials conducted mainly by the British Medical Research Council in many parts of the world, in Singapore and in Hong Kong, and in East and Central Africa, and also in Chennai and the National Tuberculosis Research Institute, Tuberculosis Research Center. Many of the principles of TB treatment have evolved from research at the NIRT, and these are the efficacy of domiciliary treatment, that TB treatment can be treated an outpatient and need not necessarily be treated in a sanatorium, the efficacy of short course chemotherapy, the efficacy of intermittent treatment, treatment given twice or 3 times a week, and the necessity for supervising TB treatment, which today goes by the name of DOTS, directly observed treatment short course. The aims of anti-TB treatment are to cure the patient and to restore the quality of life and productivity, to prevent death from active TB and its sequelae, to reduce transmission of TB in the community, to prevent the development of drug resistance both in the individual and in the community, and to prevent relapse of TB. These are the aims of TB treatment. Now, why do we need multiple drugs to treat tuberculosis? This is because in a large population of bacilli, there are spontaneously occurring mutations which render resistance, and this frequency of developing of this resistance is very predictable. For instance, for rifampicin, the mutation rate is 1 in 10 to the power of -8, that is, in 100 million bacilli, 1 will be resistant to rifampicin. For isoniazid, this mutation rate is 1 in a million, and this mutation occurs independent of each other, and therefore, in a population of say 10 to the power of 9 bacilli, which is normally what you see in a patient with cavitary pulmonary tuberculosis, there will be 10 bacilli which will be resistant to rifampicin and 1000 will be resistant to INH. And I said these two resistant populations will be mutually exclusive. So, if you use a regimen of 2 drugs, rifampicin and INH, this will take care of the resistant mutations also. To put it in another way, in a population of 1,000,000 bacilli, there will be 1 bacilli which is resistant to INH, and in a population of 100 million bacilli, there will be 1 bacilli which is resistant to rifampicin. This occurs by spontaneous mutation, not due to expression of drugs, but the chances that a bacilli will be resistant to both INH and rifampicin is a product of these probabilities, that is 1 is to 10 to the power of 6 into 1 is to 10 to the power of 8, which is 1 to the 10 to the power of 14, and this size of bacillary population normally is not seen in a patient with pulmonary tuberculosis. And therefore, this brings home the point that the MDR TB or the problem of multi-drug resistance that we see is actually created by us by bad treatment practices, and that does not occur naturally by spontaneous mutation. So, let us look at what is the mechanism of development of drug resistance and an application. Now, if you see a patient with pulmonary tuberculosis with large numbers of bacilli in his body, there will be many bacilli which are susceptible to all drugs. There will be a few which are resistant to INH, there will be a few which are resistant to rifampicin, there will be a few which are resistant to pyrazinamide. There will be no bacilli which are resistant to both rifampicin and INH. Now, if you treat this patient with the recommended multi-drug regimen of rifampicin, INH and pyrazinamide with or without ethambutol, you will find that all the bacilli will be eliminated. These drugs will kill all the susceptible bacilli. The rifampicin will kill the bacilli which are resistant to INH and pyrazinamide. The INH will kill the bacilli which are resistant to rifampicin and pyrazinamide will take care of the organisms which are resistant to rifampicin and INH. Now, if you treat this patient only with INH, what happens is INH will kill all the susceptible bacilli and also the rifampicin and pyrazinamide resistant bacilli, but the INH resistant bacilli will not be killed and they will start replicating to replace the original bacillary population. Now, if this continues for a long time, there will be a huge increase in INH resistant bacilli, and due to spontaneous development of mutation, there will be a few which will be resistant to both INH and also to rifampicin. And at this stage, if you add another drug, rifampicin, like we usually do, when a regimen is failing, we think the patient needs an additional drug, and if you add rifampicin, the rifampicin will kill all the INH resistant bacilli, but then the multi-drug resistant bacilli will start multiplying and will replace the original population, and you end up with a situation of multi-drug resistant tuberculosis or MDR-TB. Now, in a patient with pulmonary tuberculosis, it is a fallacy to assume that all the bacilli in his body are in a homogeneous population of bacilli. Actually, the bacillary population in a patient with TB exists in different metabolic populations. There will be a large number of rapidly multiplying bacilli. These are the bacilli which line the cavitary walls which are in contact with atmospheric oxygen. So, conditions for growth is good, and these are rapidly multiplying, and there are huge numbers of bacilli, and these are the bacilli that you will see when you do a sputum smear for AFB. There is also a smaller number of slowly multiplying bacilli. These will be in the solid caseous medium where oxygen tension is low and therefore growth conditions are not so ideal, and there will be also be bacilli within macrophages. Mycobacterium tuberculosis survives within macrophages, and these will be multiplying slowly, and probably there will be a third population which is dormant, and as you know, when a bacilli is dormant, no drug can act on it, but there will be spurts of metabolism growth in which drugs can act, and the drugs that we use today act to different levels on these different bacterial populations. The bactericidal drugs like isoniazid, streptomycin, rifampicin act on the rapidly killing multiplying bacteria, killing them very rapidly, and this is what results in sputum smear conversion in 2 months or so after you treat with a multi-drug regimen. The slowly multiplying bacteria acted upon by rifampicin, isoniazid and pyrazinamide, but in a much slower rate, and this is called sterilizing activity. And the dormant bacilli, probably no drugs act on them unless they have spurts of metabolism, and the drugs which act best on these are rifampicin and isoniazid. So, as we have seen, different drugs act to different degrees on different populations, and each drug has a specific role. So, isoniazid, as you have seen, is an early bactericidal activity, kills the dividing bacteria. Rifampicin is best in sterilizing activity, so prevents relapse. Pyrazinamide acts best in an acid medium. It is the only drug that acts in an acid medium, and the bacteria within the macrophages are acted upon by pyrazinamide. And ethambutol fortifies the regimen by preventing the emergence of drug resistance. So, if you look at the first line TB drugs, you will find that INH has bactericidal activity, a little less sterilizing activity, but is good in preventing drug resistance. Rifampicin has better sterilizing activity than INH. It also has bactericidal activity and prevents emergence of drug resistance. Pyrazinamide is unique in that it acts on the intracellular bacilli and therefore, it is the best sterilizing drug. It also has some bactericidal activity and perhaps has no role in preventing emergence of drug resistance. Streptomycin is a bactericidal activity, no sterilizing activity, and maybe some action on prevention of emergence of drug resistance, and ethambutol is a weakly bactericidal activity and its role in preventing the emergence of drug resistance. So, TB treatment as we see today is given in two phases, the intensive phase and a continuation phase. The intensive phase, the drugs kill the actively multiplying bacteria. So, this leads to improvement in symptoms of the patients, prevents transmission of the disease and prevents the emergence of drug resistance, and also this is the one which results in the conversion of sputum smears from positive to negative. The continuation phase is important in sterilizing the disease sites and eliminating the so called persisters, and this is what cures the disease and prevents relapse. So, the currently recommended TB treatment regimen of 6 months consists of an intensive phase of 2 months with 4 drugs, bactericidal drugs, rifampicin, isoniazid, ethambutol and pyrazinamide, followed by a continuation phase 4 months of rifampicin, isoniazid and ethambutol. Till very recently, the continuation phase consisted only of rifampicin and isoniazid, but now we also use ethambutol because in the Indian population about 10% of people of TB patients will be having INH resistance. So, the currently recommended regimen is a 6-month regimen with 4 drugs in the intensive phase followed by 3 drugs in the continuation phase. 6 months is the minimum duration. Rifampicin has to be given throughout this period. Pyrazinamide is given only in the intensive phase. Why that is so, we will see in the next slide. Without pyrazinamide, the minimum duration is 9 months, and without rifampicin, the minimum duration is 12 months. So, why we use particular drugs in a particular phase is because of results from many clinical trials done, as I said, mainly by the BMRC in Singapore and Hong Kong, in East Africa and Central Africa, and I am highlighting in this slide a few of the important studies which have helped us to define the roles of pyrazinamide and rifampicin. If you look at the Singapore BMRC studies, they studied 2 6-month regimens, 2 months of streptomycin, INH, rifampicin and pyrazinamide, followed by 4 months of rifampicin and INH, and they looked at the relapse rate at 5 years. The relapse rate at 5 years is the parameter that we use to assess the efficacy of a regimen. The relapse rate was 3%. By adding pyrazinamide to the continuation phase, the relapse rate was reduced to 1%, not a significant decrease. So, statistically this was not significant. So, the addition of pyrazinamide did not make much difference in the continuation phase. They also looked at 2 4-month regimens, 2 SHRZ followed by 2 HR, the relapse rate was 14%, and by adding pyrazinamide to the continuous regimen, there was no marked improvement. Studies done in East Africa again were very similar. They studied 4-month regimens, and they found that the addition of pyrazinamide to this regimen did not make any difference from the relapse rate. From 30 actually it went out to 32, and this 4-month regimen, which had a relapse rate of 11%, by adding pyrazinamide in the continuation phase, actually relapse rate increased, did not go down. This study done in East and Central Africa studied 6-month regimens. This 6-month regimen had only INH in the continuation phase, 10% relapse rates. By adding pyrazinamide, reduced only to 8%, again not very significant. By adding rifampicin, the relapse rate come down to 3%. So, studies like this and many other studies have shown that pyrazinamide has actually no role after the intensive phase, whereas rifampicin is necessary to be given throughout the phases of treatment. Previously, we used to classify anti-TB drugs very simply into first line drugs and second line drugs. First line drugs to treat drug susceptible TB and second line drugs to treat drug resistant TB. But in 2011, the WHO reclassified TB drugs into 5 groups. Group 1 was the first line bactericidal drugs, INH, rifampicin, ethambutol, pyrazinamide. Group 2 was the injectable parenteral agents, streptomycin, kanamycin, amikacin and capreomycin. In group 3 were the fluoroquinolones. The fluoroquinolones have been introduced into TB treatment very recently, levofloxacin, moxifloxacin, gatifloxacin and ofloxacin. And group 4 had the oral bacteriostatic drugs, weaker drugs, ethionamide, prothionamide, cycloserine and PAS. And group 5 were drugs with limited data on efficacy and long term safety like linezolid, clofazimine, amoxicillin clindamycin combination, meropenem, etc. In 2016, the WHO reclassified anti-TB drugs mainly with the idea of treating drug resistant tuberculosis. They now regrouped anti-TB drugs into 4 groups. Group A had the fluoroquinolones, which is the primary drug now we use in treating drug resistant tuberculosis. Group B had the second line injectable drugs. Group C had other core second line drugs, weaker drugs, ethionamide, prothionamide, cycloserine, linezolid and clofazimine. And group D were the add-on agents. They were divided into group 2 D1, D2 and D3. And in D2 we have the 2 new TB drugs which have been approved recently for use in multi-drug resistant tuberculosis. And now we have guideline how to use these to treat drug resistant tuberculosis. So, at least 5 effective drugs have to be used in the intensive phase, and this will consist of pyrazinamide and 1 each from group A or B and 2 from group C. If a minimum number cannot be composed, then 1 drug from group D2, the newer drugs, and drugs from group 3D should be added to make total of 5. If PZA or pyrazinamide cannot be used, then a drug from group C or D2 can be added, and if not possible, a drug can be added from group 3, D3. Agents from group D1 are added if they considered to add benefit. For instance, patients with low level INH resistance may benefit from high dose isoniazid. Till very recently, the RNTCP was using a thrice weekly treatment regimen for treating tuberculosis. The same 4 drugs in the intensive phase, rifampicin, INH, pyrazinamide and ethambutol, and 3 drugs in the continuation phase, rifampicin, INH and ethambutol, but given only 3 times a week. Now, the efficacy of intermittent chemotherapy 3 times a week or even 2 times a week treatment has been very clearly established by clinical trials done in many parts of the world. They have been shown to be as effective as daily treatment, at the same time being less toxic and also less costly. The basis for intermittent chemotherapy was based on the lag phase, where if you look at the growth of Mycobacterium tuberculosis in culture as shown in this x axis, the growth will be taking place like that. Now, if you add INH at this point, the bacteria will start dying, and then if you wash out INH or remove INH from the culture at this stage, the growth does not start increasing immediately. In fact, the decline continues for some more time before it starts increasing, and this is called the lag phase, and this is the base on which intermittent chemotherapy was established and used for very long time. But now the recommendation is to use daily treatment, recommendation both from the WHO and the RNTCP, and this recommendation is based on evidence from systematic reviews and meta-analysis. They have shown that rates of acquired drug resistance is about 3 times higher with thrice weekly regimen compared to daily treatment. And 3 times week treatment regimens in patients with initial isoniazid resistance is associated with higher risk of failure and acquired drug resistance. And therefore, the key messages from this lecture on the principles of TB chemotherapy is that the principles of TB chemotherapy have been established by clinical trials, of course, but these were preceded by in vitro studies, in vivo studies and non-animal model studies and clinical trials in different parts of the world. Many of these trials have been done in Chennai by the NIRT of the Indian Council of Medical Research. The treatment regimen consists of an intensive and continuation phase using multiple drugs. Each drug used in the treatment regimen has a specific role, and therefore, it is not a good idea to mix drugs without sufficient justification, and choosing the correct regimen based on guidelines and ensuring treatment adherence is crucial to achieve cure. Thank you for your attention.